So welcome everyone to our webinar on evolving veterans care and addressing the complex health needs of a new generation. My name is Dr. Samir Sinha, and I'm going to be moderating today's session. So I just want to welcome everyone here. I just want people to please note, we'll just go to the next slide, that all of our audience member microphones are muted today, and that if you have any questions for our speakers, to the bottom of your screen, you'll see a toggle bar. There's a Q&A box that you can use at the bottom of your screen. So please pose any questions that pop up for you there so that we can attend to those. And if you have any technical issues during the webinar, please let us know using the chat box as well. So thanks again for joining us as well. We'll go to our next slide. We just wanted to start today's session with a land acknowledgement. The National Institute on Aging, or the NIA, is a Toronto Metropolitan University based in Toronto, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans and all newcomers, have been invited into this treaty in the spirit of peace, friendship, and respect. And today we really want to gather together on this land to really discuss veterans. And we want to honor and recognize the past, present, and future Canadians who served their country and thank them for their service and sacrifice on all of our behalf. So I just want to introduce quickly the fact that today's webinar, we are joined by a number of guests to discuss the health needs of a new generation of aging veterans. In particular, we've got Dr. David Pedlar, who's the Scientific Director of the Canadian Institute for Military and Veteran Health Research. We've got John Muscedere, who's the Scientific Director of the Canadian Frailty Network. We've got Dr. Ritchie, who's an Assistant Professor at the Trent Fleming School of Nursing. And we've got Dr. Madison Brydges. She's a health policy researcher with the National Institute on Aging, and she was the lead author on a recent report that we just published around the needs of our aging veterans. So in this webinar, we're going to really focus on by starting describing Canada's veterans and Canada's history of caring for its veterans, and that section will be led by David Pedlar. Then John Muscedere is going to, and Ritchie and Madison Brydges will each discuss a key challenge facing Canada's aging veterans and how we can better support our current and future veterans. And then there's going to be time in the latter half of our session for question period at the end. So again, please put any questions that may come to mind in the Q&A box at the bottom of your screen, and then we'll reserve those for the Q&A section of this as well. So I wanted to start by speaking about who are Canada's veterans. And to begin with, let's describe who they are. We know that today nearly 500,000 veterans are aging. 66% of our veterans are currently 55 years and older, and 94% of today's veterans are those who served after 1954, after the First and Second World War and the Korean War. So these are generally folks who have experienced different forms of combat, different forms of service, and are therefore positioned to age with different circumstances and unique challenges as well. Go to the next slide. We also know that our current veterans are certainly aging differently than previous generations of veterans. We know that from several decades of health research that some of our veterans have higher rates of chronic conditions like back pain, arthritis, and mental health conditions compared to Canadians of a similar age and sex. We know that our veterans have rising rates of comorbid physical and mental health conditions. Notably, PTSD has become a common comorbid condition accompanying chronic pain or physical conditions. We also know that veterans have higher rates of some health conditions, including higher rates of hearing loss that place veterans at an increased risk of frailty or dementia. And then these challenges don't mean that veterans can't adapt to their health issues, but what it does mean is that we need to start thinking about how best to support this group as they age and start thinking about the programs and policies that will allow them to age in place as well. Finally, I wanted to speak to the social characteristics of today's veterans, because we now know that more veterans are living alone at higher rates than the average Canadian. Currently, 1 in 4 veterans is currently living alone, and this puts them at increased risk of experiencing social isolation. And when we think about aging or those living with disabilities, we know unpaid caregivers are essential in order to help them to stay healthy and independent for as long as possible. And so, how do we better support this group of veterans who are living on their own? And how do we also think about those who are serving as unpaid caregivers and providing really key supports to also better support veterans who might be living on their own? And then how do we think about veterans who may not have any supports in the community beyond what Veterans Affairs and other government services can provide? So we'll go to the next slide, and I wanted to again introduce Dr. David Pedlar, who's now going to speak to how Canada has cared for its veterans in the past.
Well, thank you, Samir. I appreciate the opportunity to share some ideas. I want to highlight a few points really of the history, but the purpose of the history today is to try and frame the report that we've recently released. That's with 3 points. One is I wanted to highlight the important role veteran programming in Canada has played, not just for veterans, but for the healthcare system as a whole, including aging care. Second, to talk about the concept of pre-aging or accelerated aging, which started in World War I and has sort of been part of the story of veteran aging since that time. And finally, I wanted to speak about the idea of a report card. How well has Canada done in the last century in terms of caring for aging veterans? So let's take a look at the big picture first. World War I and World War II involved huge mobilizations of Canadians to fight wars. In World War I, 650,000 were mobilized in a country of only 8 million, and in World War II, 1.1 million were mobilized in a nation of 11 million. The risks and hazards of war and conflict are well known. In this case, thousands died, tens of thousands were injured. They were in need of treatment, rehabilitation, and compensation, and hundreds of thousands required support for transition and reintegration to civilian life. These huge challenges had impacts. One was veterans were established as a unique population that required nationwide attention for health needs, transition to civilian life, and they received a special status. Another was the creation of health infrastructure across the country, in a small country, to treat and care for these cohorts of veterans and to provide care across their life course. Veteran care is unique in some regard because we tend to follow cohorts of veterans across their life course, especially with health issues related to military service. So that's at release when they're younger, through midlife and into old age. And for World War I veterans, they reached old age in the 1960s and 70s, and World War II veterans in the 1980s and 90s. But today we're going to be focusing on post-World War II veterans, including those who would have served in Afghanistan, the largest deployment since World War II. And go to the next slide. So an interesting policy driver that emerged in Canada between World War I and World War II was this idea called pre-aging. That's the idea that the wear and tear of military service impacted veterans through their life, but also in later life, sometimes 50 years after release. So, for example, when the War Veterans Allowance was created in 1930, that was an income support program for struggling and indigent veterans. The age of eligibility was purposely set at age 60 for men, 10 years younger than for the old age security program, because it was believed that veterans aged prematurely. And the word at that time was called burned out. So this idea, and I don't present it technically, but it has remained in the discussion of veteran care since World War I, and is actually currently part of discussion called accelerating aging in the United States around veteran care. So finally, I want to talk about this idea of a report card, and you can go to the last page. Next slide, sorry. So I do want to show that in this era, it's a different era, but there's been all kinds of conflict and deployments, and some of them you will know have been notoriously difficult, including deployments in Rwanda, Somalia, and Bosnia. but also the Gulf War, which is the Afghanistan War, which is our largest deployment since World War II. So finally, this idea, though, about a report card. So there have been historians who have looked at some of these questions. How well did Canada do in aging care? Well, many regard Canada's treatment of World War I veterans as a terrible failure. Historians have said that World War I veterans were warehoused in ward-type care, and they did not benefit from best practices in geriatric care that were being developed at that time. However, the failures of World War I became the lessons learned to benefit World War II veterans when extensive planning and preparation for aging took place, that including a review of best practices internationally. And that led to things like aging in place leadership to enable people to age at home as long as possible as a foundation for veteran care. And some of you will be familiar with the Aging Veterans Program, later called the Veterans Independence Program, and also strides that were made in recognizing the important role of informal care providers who have always played a central role in veteran care. So that actually brings us to this era, which will be sort of, I think, the third time that we've really looked at aging in the big picture. Some of the great work that's been done in the past is carried forward, but this is really an opportunity for us to write the story around what happens to this cohort of veterans. So, for example, some veterans who served in Afghanistan, they'll be reaching old age and still be living for most of the 21st century. So it's really up to us to figure out what kind of innovation or step-by-step change we can consider in order to make sure that the story for this group of veterans is a really good one. So thank you.
Thank you so much, Dave, and really appreciating you giving us some perspective and understanding what some of the challenges that our veterans have faced over the years. And wanted to now bring in John Muscedere, Dr. Muscedere, to speak to veterans and frailty and what are some of the challenges facing them as well. So, John?
Great. Thank you, Samir, and it's a real pleasure to be on this webinar. And I just want to start off with saying that it was a pleasure for the Canadian Frailty Network to work on the report and the partner development of the report. Just a bit of background: the Canadian Frailty Network. So we're a national network focused on improving care for older adults living with frailty. We're committed to creating a sustainable, healthy aging solutions for frailty care, for becoming a key resource for public healthcare professional and policymakers. Just to start off with, just the definition of frailty. So frailty is a medical condition characterized by reduced health, function, and ability to live independently. Factors such as poverty, social inclusion, exercise, nutrition, polypharmacy, loneliness affect the development of frailty. And frailty increases your risk for poor health outcomes over the long term, including increased need for hospitalization and increased need for requirement for long-term care. Why we're interested in frailty is in veterans is that there's been 3 decades of health research that demonstrates that veterans are aging with more complex and physical health conditions, as Dr. Pedlar has said, which may increase their risk of accelerated biological aging and frailty. The frailty, because frailty is a complex and multifaceted condition, it requires tailored supports for the maintenance of independence and quality of life, especially for veterans as they navigate the challenges of aging and chronic health conditions which come on earlier in life. The key concept here is that aging is heterogeneous and it affects different populations differently. So veterans are a good example of a group of people which age differently and where frailty may come on earlier. And where interventions may help, and I'll talk a bit more about those. So when we look at the occurrence of frailty, presence about 1.6 million Canadians live with frailty, and this is expected to increase to 2 million in the next 5-6 years. The specific prevalence of frailty among all Canadian veterans remains unknown, but in 2023, there were an estimated 14,000 veterans experiencing frailty that qualified for VAC's VIP services. A study of U.S. veteran by the U.S. Veteran Affairs in over the age of 65 revealed that the prevalence of frailty among veterans was approximately 3 in 10, with a greater prevalence of frailty among older veterans, African Americans, and Hispanic veterans. The prevalence of frailty increases with age, but there are certain risk factors that can elevate your chances of developing frailty, and certainly a lot of the things that are common in veterans predispose you to frailty. The other aspect of this is that frailty is not an inevitable portion of aging, and frailty can be mitigated or prevented by appropriate intervention, especially earlier on. Once frailty is well developed, and the chances of mitigating it or reversing it are less. So the earlier on that you can intervene, the better. And the interventions that we know that can impact the development of frailty or mitigate it or prevent it are encompassed in the AVOID frailty framework. So AVOID is an acronym that stands for promotion of activity and exercise. Certainly, the more that's promoted, exercise and activity have multiple beneficial effects in people. Promotion of vaccination, such that you receive appropriate vaccinations in somebody who is older, who is developing chronic medical conditions. Minor illnesses such as an influenza or other infections can cause irreversible changes in their health status. The O in AVOID is for optimization of medication, so that you're on the appropriate amount of medications for the stage of life course. Too many medications are associated with development of frailty, but then also not being on the appropriate ones for prevention is also an important part. The I in AVOID is for isolation or promotion of social activity. Attention to loneliness are very important things that you can do and certainly isolation and loneliness are risk factors for the development of frailty. And finally, the last one is diet and nutrition. So appropriate diet and a well-balanced nutrition are important to age well, which may be problematic depending upon socioeconomic status and your ability to afford healthy foods. So based on all the evidence, it's important to have a healthy aging strategy going forward that addresses all the things that we know that can prevent frailty, the things that I talked about that are in the AVOID strategy. A life course perspective is crucial, and especially aimed at delaying or preventing frailty or development of other comorbid physical and mental health conditions. And finally, we need to better address the knowledge and practice gaps for healthcare providers. We know there's some evidence of frailty in veterans, but I think it would be important to have better evidence, especially as to the occurrence of frailty in Canadian veterans, and also to look at the uptake of preventive or mitigation strategies in this group. And finally, it's important to promote education and training for healthcare professionals and primary caregivers, since there's a lot of nihilism towards the development or the aging process. But we know that there's strategies that you can put in place to mitigate that. And the more that we get this knowledge out, the more that we'll be able to improve outcomes going forward. So I'm going to end there, and I'd be happy to answer any questions. And it's a pleasure to be on this webinar. Thank you.
Thank you so much, John, and I really appreciate you talking about, the challenge of frailty that's increasingly facing our aging veterans. As Dave talked about, we've known about this idea of accelerated aging for some time, and now we're able to better characterize it, but there's still a lot to know. One of the other big challenges facing our veterans is growing issues of mental health challenges, including PTSD and dementia. And so to discuss this a bit further, we've got Dr. Kim Ritchie now. So Kim, over to you.
Thank you very much, Samir. It's a pleasure to be here today and to be part of this panel on aging veterans. Today, I'll be talking about, as Samir said, one of the complexities facing older veterans, which is PTSD. And also, I'll be sharing a little bit about PTSD and dementia, and then some strategies about caring for older veterans with these complexities. And the first idea is that military service has been called a hidden variable among aging veterans. So the long-term effects of military service are there, but they tend not to be recognized or considered once veterans reach older age. And one of the things that tends to be hidden is PTSD. But PTSD does appear to be a significant issue for many older veterans, with studies suggesting about 8% of veterans living in the community and about 20% of those living in long-term care meet PTSD diagnostic thresholds. One note here is that we really have very little information about PTSD among older women and other equity-deserving groups of older veterans. So this is an area where we really definitely need some more research. Importantly, it also appears that PTSD symptoms can increase in older adulthood, particularly during specific times of stress or change, such as retirement, the onset of physical illnesses, the loss of loved ones, the onset of cognitive impairment or dementia. Next slide, please. And when we specifically look at PTSD and dementia, several studies have suggested that they have a bidirectional relationship. So on the one hand, PTSD has been described as an independent risk factor for the development of dementia. And on the other hand, there seems to be this worsening or reemergence of PTSD symptoms following the onset of dementia. And really, there is very little information about this combination of PTSD dementia or co-occurring PTSD and dementia, although a few studies have suggested that symptoms associated with it are war-related nightmares, anger, suspiciousness, flashbacks, anxiety, depression, and aggression. Next slide, please. And because we have so little information, one of the challenges right now is being able to identify PTSD symptoms in veterans with dementia. In a study a few years ago, a group of healthcare providers with expertise in this area shared that veterans who have this combination of PTSD and dementia tend to have a greater intensity in their symptoms, and that they always seem to be present and underlying every care interaction compared to veterans without PTSD. And another challenge is that veterans may not have wanted to share or subject painful or distressing memories from their military service with their family and friends. So many times family and friends are not aware of a history of past trauma, and veterans themselves, understandably, may not want to talk about this when they're in the healthcare system. And the two quotes on this slide are from healthcare providers that were in the study that really illustrate the perspective of some of these challenges around identification. The next slide. And this combination of PTSD and dementia can also result in greater care complexities and even different responses to many of the usual types of care strategies by healthcare providers, such as redirection. And what we have found is that more effective care approaches seem to be the ones that take more time. They also emphasize safety and build trust, and also offer greater care and greater flexibility in their care routines. Next slide, please. So in summary, it's important to be aware and to consider the possibility that PTSD can co-occur with dementia. And this is especially relevant when caring for older veterans or other occupational groups who are at higher risk of PTSD. Another recommendation or strategy is that when caring for veterans with PTSD and dementia, one approach that may be effective is focusing more on the relational aspects of care in an attempt to more intentionally establish safety and decrease sense of fear in those who have PTSD. And finally, there's a need to increase awareness and knowledge among healthcare providers who provide care for older veterans across the care spectrum. So from primary care straight through to acute care and long-term care and community care, and to include information about PTSD and dementia in care resources, in guidelines, and to create more knowledge. Thank you very much.
Thank you so much, Kim. I really appreciate you walking us through, especially the particulars of why PTSD is an under-researched area, but one that we need to take quite seriously in terms of caring for our aging veterans. So appreciate that. We're now going to hear from Dr. Brydges, who's going to speak a bit more to what Kim alluded to as to our growing groups of equity-deserving veterans as well. So, Madison?
That's great. Thank you so much, Samir. So to begin, we know that today's veterans are more diverse. About 16% of veterans are women, 5% are Indigenous, and 4% are racialized veterans. And again, we're seeing a bit smaller proportions when we look at veterans over the age of 65. So we know that Canada's currently serving military are more diverse than this current veteran population. So we'll continue to see a more diverse population moving forward. Even with this increased diversity, equity-deserving groups of veterans are underrepresented in discussions about aging, and we see that these gaps are spanning research, practice, and policy. So when we think about the challenges facing older veterans from equity-deserving groups, we really need to look at this from a historical perspective and understand how systemic forms of discrimination, including colonialism, racism, sexism, and homophobia, have been experienced by these groups throughout their lives. There is long-standing evidence that historically marginalized groups experience disparities in access to healthcare and gaps in inclusive, culturally safe care. For instance, the recent Standing Committee on Veterans Affairs report highlighted how women veterans continue to face gaps and barriers in access to care, both during and after service, and a lack of recognition of women's specific health conditions. When we look at one of the most popular Veterans Affairs Canada programs, the Veterans Independence Program, a 2020 evaluation found that Indigenous veterans report the lowest levels of satisfaction with this program when compared to non-Indigenous veterans. And to us, LGBTQI+ veterans continue to experience lifelong trauma and health impacts from the LGBT purge, which was a period from the 1950s to 1990s, during which individuals were targeted, harassed, abused, and fired in the Canadian Armed Forces, RCMP, and Federal Public Service. We also know there are a number of different military-specific risk factors to think about. So we know that veterans from equity-deserving groups face an increased risk of sexual assault, discrimination, and harassment. Even with about half of sexual assault incidents going underreported, 1 in 4 women Canadian Armed Forces members and 1 in 25 men have experienced sexual assault at least once since joining the Canadian Armed Forces. This is significant because it's well established that trauma can have both short and long-term effects on well-being and physical and mental health. Lastly, we do have a bit of research that looks on the health outcomes of veterans. Most of this has looked at this using a sex or gender lens. And we can see that when compared to the Canadian population, women veterans are reporting higher rates of PTSD, back problems, chronic pain, and help with activities of daily living. However, we really have very limited Canadian health data on racialized and Indigenous veterans, not only of health throughout their life, but also into later life as well. This also means we don't have a good picture of what aging well looks like for these groups. And I think there are stories here of strength and resilience that we really need to hear so we can learn how to better support those who need it. So what can Canada do now to improve care for veterans from equity deserving groups as they age? So the first is we need to strengthen the availability of inclusive, culturally safe, and specialized services. So this begins with improving healthcare provider knowledge, particularly as it relates to these approaches to care. Healthcare providers also need better knowledge of the veteran and military specific context in general, which would include knowledge about what services and supports are available to veterans. We also need to make sure that access to culturally safe and specialized care exists across different healthcare settings, so from home care to primary care to long-term care. Secondly, we need to address these gaps in research and program evaluation. I really here want to echo the recent Standing Committee on Veterans Affairs report that recommended a research agenda for women veterans, and I would extend that to equity deserving groups of veterans as well. And as researchers Davis and Eckler point out, research really needs to be inclusive and participatory and driven from the experiences and perspectives of the groups that it's meant to understand and support. So to do this means we need to start building and improving research capacity and expertise in these areas. And lastly, we really need to know if the programs and services that are supporting veterans from equity deserving groups are how they're functioning and are they contributing to further inequities. Here, we can't just look at health outcomes. We really need to understand veterans' experiences of accessing care and the barriers to accessing care as a means to help improve access to these services. So thank you so much, and I'll turn it back over to Samir.
Thank you very much, Dr. Brydges. And so just wanted to talk a little bit about some of the next steps and the work that we've been doing as colleagues here. As mentioned, as you'll see at the bottom of the slide here, 3 organizations came together: the National Institute on Aging, with the support and the funding of CIMVHR and the Canadian Frailty Network. And this is a great partnership because it allowed us to really work on developing an in-depth report that really looked at who today's veterans are, the challenges that are facing this aging population, something that I think we often overlook, and then specifically what are some of those challenges, but what are some of the opportunities. It also allowed us to do a review of how not only is Canada responding through Veterans Affairs Canada and what provinces and territories are doing, but also what other countries like New Zealand, Australia, the United Kingdom, and the United States are doing as well. And these things that we can learn for best practices. And all together, we were able to take all this information and then come together and develop 6 key recommendations that really talk about developing a healthy aging strategy, evolving the Veterans Independence Program, again, a very key flagship program started by Veterans Affairs over 40 years ago to really support veterans to age in place and to also support often family caregivers who are providing care and support for them. Really kind of making sure that we're doing things, not only this, but other things to support Canadian veterans to age in the right place and think about the needs of their caregivers. And then finally, we heard a little bit from Dr. Ritchie about mental health care and trauma-informed care and how that needs to be integrated into aging care. And then from what Dr. Brydges is talking about, how we need to have greater research about aging veterans, especially from equity deserving groups. So those are the 6 overarching recommendations that we came at. And I encourage you to take a look at our report that we just released a few days ago so that you can see a little bit more about what we were looking at and really what we're encouraging and calling on people across our country to get involved in. There really is a need for prevention, for expanding and enhancing existing programs to address gaps, particularly as it relates to frailty, mental health, support for veterans from equity-deserving groups. And addressing these gaps is really going to require cross-sector, federal, but also provincial and territorial collaboration, as well with our veteran community organizations as well. Go to our next slide. And so at this point, we have the rest of our webinar to take questions and to also have a more fulsome discussion. I see that we already have one question in the chat. Just again, if you have any technical issues, please put those in the chat function in the chat box. And if you have any questions you want to ask towards any of our panelists, please, we encourage you now to start putting those into the Q&A box as well. One question that's been asked is that people will be very interested in getting a link to the report. And I believe our coordinators here, Jen and Joanne, will be putting a link to the report into the chat function as well. We also have, so one question we have is from Christina, and she asks, in order to address the important priorities presented here, has there been a discussion with the Tri-Council funding agencies for targeted research opportunities related to veterans' health? So thank you, Christina. And I might start that with Dave, because certainly CIMVHR, I think, has been quite involved in supporting research around veterans' health, but you may have some more knowledge about Tri-Council funding support.
No, I'm not aware of that discussion taking place. However, Veterans Affairs has an ongoing relationship with federal research agencies. So we would have to explore if anything recent has been done in that area. So.
Perfect. Okay. And certainly, I think some of the opportunities of funding that come through Tri-Council do not exclude us focusing our efforts to take a look at veterans issues. But as Dave was saying, I don't think there's been veteran-specific calls that have become Tri-Council. I'd invite if Kim or John have any further comments on that. Otherwise, we can move on to the next question. Okay. Dr. Brydges, Madison, there was a question saying you're sharing some stats on. They were asking if you could share some of your stats again on MST.
For sure. So the military sexual trauma statistics. So this is actually coming from the Atlas Institute, which recently published some data that was taken, I believe, during 2016 to 2018. It was a survey on sexual misconduct in the Canadian Armed Forces. And that survey found that since joining the Canadian Armed Forces, 1 in 4 women and 1 in 25 men have experienced sexual assault at least once.
Perfect. And then, okay, perfect. And then Amanda asks us the question, VAC contract facilities across Canada have considerable expertise in veterans care, and we have come together to propose a regional hub and spoke model to support the 6 recommendations that you propose. Can the speakers comment on this proposed model? And I think the proposed model, let me just go back. The proposed model being thinking about this hub and spoke approach. Dave, do you want to take the first chat about this?
I'm not familiar with the exact details of the model, but the idea is a good one to connect work that's being done, like this report, with practitioners who are seeing veterans every day. And that could also include, though, the operational stress injury clinic network as well, that deals with military personnel and veterans with mental health conditions. So, the concept is a great one.
I invite anybody else to speak to this too, but I think one of the thoughts as well is that while Veterans Affairs Canada is providing services towards veterans, through its through its role as a federal kind of agency, if you will, of government. Obviously, all veterans are able to access healthcare services that are principally run by provincial and territorial governments. So there are obviously already regional differences between what veterans, can access as regular users of our healthcare systems, how responsive they are to veterans' needs, and then how those integrate with additional services being provided by Veterans Affairs. So I think a regional approach, I think as Dave said, makes intuitive sense to understand additionally what some jurisdictions are providing and how we can really prioritize veterans' health locally as well. And Dr. Brydges, Madison, I'd like to ask you, one of the examples you found that I think is kind of interesting is how the UK, or in England specifically, in their NHS, they're trying to make their primary care system more responsive to the needs of veterans. Did you want to just mention a little bit about how why you highlighted that example and how that could be another way to support veteran health?
For sure. So in the UK, they have a accreditation program that's in the primary care system where primary care practices have to meet various requirements for accreditation, and that includes having a military veteran identifier within health records and having someone on a health team that has that expertise around veteran health. And it's also meant to encourage referrals back to veteran-specific services. So when we came across this program, we just thought it was such a great innovation in primary care and in that system linkages and care coordination that we'd really like to see. And also just increasing that veteran context and specific knowledge within the healthcare system in a really systematic way, I think could be really valuable in addressing some of the challenges we have with coordination of care, with ensuring that we can get the right services and, importantly, veteran-specific services and supports to those who need it.
Great, thank you. There's another question specifically, and John, I wonder if Caprice, you might be able to give us or add in a little bit more around your question around frailty. So you said, with respect to frailty, was purpose and meaning considered? And I don't know if there's anything further, but I don't know, John, if that's helpful, or we can wait for Caprice to give us a bit more clarity on that.
It'd be great to get a bit more clarity, just so that I understand the question a bit more.
Perfect. Okay. Caprice, so we invite you to just clarify that a little bit further so that Dr. Muscedere can answer that one. But we have a number of other questions. So David notes, for example, that identifying veterans in the ER or other medical triage venues needs marked improvement. Have you considered a POPI on an OHIP card? My advice is his advice. He says, staff MD Sunnybrook veterans that way. So again, that's, I think, Madison, you just talked a little bit about different ways in which the NHS is trying to better help us identify, because another attendee noted there are also an estimated 150,000 older veterans of other countries living in Canada, and how are these individuals being included in research? Is it of note that the census question does not ask about them? So, I don't know if you want to start with that, Madison, and any of our other panelists are welcome to talk a little bit further.
For sure. I think just to add a quick comment there, I think that identification piece, you would want to see it in different sectors. The UK example is in reference to primary care, but it would make sense that we would want for there to be that veteran identification for the purposes of better understanding and caring for this group and connecting them to those veteran-specific resources. And then that could be something that would transfer to other settings as well. And, that mention about veterans living in Canada from other countries, that veteran-specific context or knowledge, would still, apply in some ways in that sense. And that would we have a better awareness of some of these issues around whether it's mental health concerns or frailty, that now we're equipping our healthcare providers just with more resources and tools to better serve the needs of this population.
Thank you. And Madison, if you, in the Q&A function there, if you look at Lisa has put a link into a study and wants to know, is that identifier based on this study? So maybe you can take a look at that as well. But I just want to see if Dave, you wanted to comment a little bit further on this as well.
Well, I think military service and issues and kinds of exposures that happen during military service would be universal to some extent in terms of some of the risks that would be presented. And so from my point of view, it would probably be a good part of primary care intake across all populations, not just Canadian Armed Forces members. And then I can't recall, but John Muscedere would know probably around whether the screening question in the Canadian longitudinal study on aging, I'm trying to remember if it included just Canadian Armed Forces veterans or if it was open in a way that others could be identified. If that were the case, then it would be possible to do more analysis on that. But and then also, of course, we have significant refugee populations who have had exposure, including military service. So right now there are many Ukrainians, for example, who have come to Canada related to the circumstances in Central Europe, Eastern Europe right now, which would be an example of populations or veterans who would have experienced possibly mass trauma or extreme trauma in military circumstances. So I think a wider screening in primary care, as well as identifying CAF veterans, would be part of a better health strategy.
Thank you. And Christina notes that for the CLSA, the veterans identifier question includes the ability to identify veterans from veterans of other countries. So that's helpful there. And lots of comments about kind of ways in which we can add potential identifiers. Lisa has a suggestion noting that there's some possible military identifiers that could be used, to help better identify people, because I think David is also notes that sometimes homeless veterans, for example, will not volunteer or identify themselves, I think, and notes that dementia can sometimes mean that someone may not be able to easily respond or answer to that question as well. But David, did you have a thought on this as well?
Well, another direction. It's a different direction than the one that's been suggested, which was a great idea about identifying veterans. Has been that for about a decade now, there's been extensive work done with Statistics Canada developing a veteran registry. And that would be part of the broader linkage strategy that Statistics Canada has, so that it can make more complete use of the many data sets it has. So, so we're approaching a time now when veterans can be identified as subsets that can be studied across numerous data sets. I don't want to quote the number, but it's probably 30 or more data sets. So not so much for health professionals, but definitely for researchers. There would be really new opportunities to look across all of the kind of dimensions that frailties mentioned and measured, and potentially to take a look at how Canadian Armed Forces veterans do in the context of what Statistics Canada has worked a decade on generating. So that should be available in data centers, if not now, soon. I was updated on it a few weeks ago.
Absolutely. And so some more suggestions again about different ways in which we can promote a standardized question. For example, someone typed in a suggestion of, have you ever served in the Canadian military, as maybe one way. I think, as David, you mentioned that there are various databases. And right now, as I understand, Veterans Affairs Canada doesn't proactively go out and have lists that they can use from, say, people who've recently served or served in the past, that veterans have to self-identify in order to access services. So sometimes just even estimating the actual number of potentially missing people, as Lisa notes, if people have brain injuries, dementia, that would affect the ability to self-identify. So there really is kind of a need to make sure that we really do support people to be able to be identified or self-identify as well, because we're obviously missing the opportunity to be able to support people that way as well.
The questions have been developed and tested. I think there's at least one publication in the Journal of Military, Veteran, and Family Health, which CIMVHR hosts. But there would also have been testing in recent veteran surveys as well. So it's that whole thing around what is the best question has been refined since at least 2008, I think, when the first one, which wasn't actually the best question, was put in the CLSA. But questions have been refined since that date. So there is technical direction available on those questions, which could be available through Veterans Affairs for sure. That's done a lot of the networking and background on building these things.
Okay.
With that.
We actually, sorry, I was just going to add that we actually are looking at this in some healthcare organizations. So about a year ago, we formed a community of practice to focus on some of the issues around aging veterans. And this was identified as a large issue that we needed to address right away, was the identification of veterans across the care spectrum, and particularly at care transitions. And how do we do those care transitions better from one care setting to another care setting, particularly among those who have TBI or dementia, as you mentioned, Samir. And I think asking the question, like, what is the right question? And so we've been asking veterans, what is the right question that we should be asking? Because as was already identified, not all veterans identify with the term veteran. They identify with other ways. I'm retired, or other ways to identify. So I think understanding what is the right way to ask that question is really the first step in being able to better identify our veterans across the care spectrum. So I think once we have that question down, then I think we have to look at how do we go about identifying it from systemically across the care system, so our healthcare institutions and within our reporting structures within there. But how do we also at the clinician point identify that? Are there questions that we can be asking more regularly? In the US, they have a strategy that they developed about 10 years ago or more, where they really promote in their education of healthcare providers and in the actual practice of healthcare providers. They have a question. They say, have you ever served in the military? And that's just part of your standard clinical assessment that you would ask each and every person when they walk in your door. So I think, that idea of many different ways to be able to identify is probably the best strategy.
Brilliant. We had, just going back to John Muscedere, we had Caprice was able to give a bit more clarification on their questions. So they said, in terms of activities such as physical and social activities that were mentioned to mitigate frailty, were these activities considered to be meaningful and purposeful?
So thank you for the question. So to look at healthy aging strategies, which include activity and reduction of social isolation or loneliness, the more activity that you do, the better, and it obviously age appropriate and appropriate for your physical status. Activities that promote reduction of social social engagement, so such as group activities, such as group exercise activities. Those things are probably on face value to be the most helpful, since they're doing two things at the same time. They also increase your risk of your compliance or ability to keep it up. So group activities, things that are more meaningful to the individual, are much more likely to be maintained over a long period of time, and they're probably the most beneficial in the long term.
Thank you very much, John. There's some comments about, again, we have some specialist facilities and centers like the Sunnybrook's Veterans Center, for example, and being aware of it as a resource and as a center of excellence, and also noting that veterans, as they need long-term care services, it's hugely expensive. But how do they know about certain facilities, for example, mentioning Sunnybrook and St. Anne? And then also there was Caprice is asking, I understand that VAC is moving away from supporting beds in long-term care settings. Is that because the focus will be on remaining at home? So, Madison, I might pitch over to you about just kind of, again, what we've learned about kind of these strategies to support aging in the right place amongst our veterans.
Sure. So we draw a lot of attention to this in our recent work. And in the NIA in general, we've really focused on, we really want to support programs and services and policies that help Canadians age in the location that they want to, that meets their preferences and needs. And we view that the same for the veteran context as well. And part of what that looks like and that we draw in the report is that we often have home with support, and that might look like home care, or in the case of veterans, we know there's the Veterans Independence Program, which provides support for groundskeeping and housekeeping as well. And then it's long-term care. And there's that missing middle. There's that missing kind of continuum of long-term care that we can insert kind of other options that can help veterans age in different, more supportive environments. So we draw some examples to programs we're seeing in the US around more supportive home-based long-term care options, other kind of more small home type models of long-term care. So when we think about veterans aging in place, it's really about broadening out that continuum of care and not having it really just be home with support. And then when you kind of exhaust that resource, now your only option is long-term care. We really want to see more support in the home and community environment to meet varying needs, to meet these groups who might be experiencing frailty or who might need more intensive support.
Okay, thank you. So we only have a few minutes left, and we have 7 additional questions or comments here. So I'm just going to do kind of a little bit of an omnibus tour through just some of the comments that have been made. Audrey notes that social enterprise and grassroots community affiliations are great mediums through which to identify veterans and deliver some of the support proposed here. Government and formal structures are not always the most efficient at reaching the most in need. So any comments on how delivery channels can include community and social enterprise? I just want to see if anybody wants to comment on that.
I'll just quick comment on that. I think that's a great idea. The social and engagement and through local organizations which maintain cohesiveness are probably great things if they can be promoted and supported, and also allow self support between the people participating in those programs. So yes, absolutely.
Perfect. And again, it's I think we really did focus quite a bit on what are some of the different kind of services available beyond just kind of government services when we did our jurisdictional scans in Canada and other places. And so the voluntary and charitable support sector is certainly one that has played an incredible role and will continue to do so. I'll ask okay. We've got lots of last things coming in here. I'm just going to, again, do a quick tour. Again, there are some suggestions about using identifiers on OHIP cards, like putting a poppy symbol. So again, a lot of comments coming through about how do we actually better identify those who might need supports, for example. There's a lot of folks sharing about some of the research that's going on. Nora shares that currently there's research being done on military and veteran cultural competencies. And so that's again encouraging to hear, especially given the growing diversity of our services. The changing nature of service. David has commented that we also have to be aware of how many people have served during the Cold War and how Cold War veterans could be at increased risk of PTSD, which can again have those delayed onsets that I think Kim spoke to as well. And we certainly, people are asking, does the report, talk about transitional care settings and other ones as well? We certainly do feature some of the innovative models that have existed. And I think Madison, Dr. Brydges did mention some of the other interesting models that we've seen in other settings as well. And I think there's just kind of an interest in saying the importance about training modules for primary care and specialists be a good natural next step. Because again, there's one aspect about identifying people, but also there's also the importance of making sure that we really educate ourselves and each other in terms of supporting that. So thank you. I'm going to stop. We've gone through 26 questions in the last 20 or so minutes, and unfortunately we can't get through all of them at this moment. But we'll put up our last slide here because I just want to again say thank you very much to our panelists as well, who've come out to join us today. And were very much instrumental in the development of our report. Dr. David Pedlar from CIMVHR, Dr. John Muscedere is the scientific director at Canadian Frailty Network, Dr. Kim Ritchie, who's an expert in mental health, PTSD, and veterans, and provided her support as an expert reviewer and as a researcher in the space, and Dr. Madison Brydges especially, who actually led the hard work of developing this report and was the report's lead author. Again, we'll make sure that folks have a copy of the link to the report. Hopefully that'll provide more information. And if you do want to follow up with any further questions or thoughts that you weren't able to share today, please, you have our email address, you have ways to connect with us through the web or on social media, and we do look forward to hearing from you. So again, thank you for all of you who participate in today's webinar. We really appreciate your attention and support. And again, thank you to my fellow panelists today who really helped to support us on understanding what are some of the opportunities and challenges facing today's veterans as well. Thank you very much.